This is for our information only, and whenever so they increase the pneumonia, asthma, decrease low growth and function. So it affects more people than any other air pollutant and commonly used as a proxy indicator or surrogate indicator of air pollution in a more. We cannot talk about ozone, the level of ozone. We cannot talk about the level of what do you say, sulfur dioxide, but we can. Particulate matter is one which is always discussed. For that reason, we always determine the air quality index based on particulate matter. Friends, do you know what is the, I just googled today morning what is the QLI of Vadagara. You can just Google right now what is the air quality index of Vadagara. It is 36. If you talk about the particulate matter, it is 36. Kozhikode is 19. And what do you see? We are in the best zone. It is good. We are in the green zone. Good. We are absolutely blessed. But then there is pink. When I went to Jaipur, that time Jaipur, even though called as pink city, Jaipur was it is not at all pink. It was worse in the red that time. You always think about big cities. That was around 250, maybe a year back when I. So in Kerala itself, Pathanamthitta, you'll be interested to know that Pathanamthitta and Punuru, that area has got Kuttalam, that the high range area, has got the best air quality index. They maintain the air quality index something around 20 to 30 over the year, seasons. But it varies. And Kerala per se, the worst season is here October, maybe the winter sets in, the rainy season, and then North India, this is the time when you get the worst season, after Diwali. The crackers are there, all crackers, every house, crackers, and ultimately the particulate matter is flooded in the atmosphere. So North Indian scenarios after Diwali, post Diwali, the incidence of asthma increases, incidence of respiratory infections increases. Why? Mostly. And 2 or 3 years back, I think, I am not sure, 2019, I think, where Haryana in the Delhi suburbs, they had an air quality index of something around 600 plus. And that is the time when India was in the news for all the bad reasons. We had something at the, for many things, but even WHO, the global rating agencies put India in the blacklist just for that, the Delhi suburbs. That they say that the harvesting season, after the harvesting season in Haryana and other Delhi suburbs, the wind breezes across Delhi, and that used to be. And that time, the Delhi Chief Minister Arvind Kejriwal, he introduced that alternate day vehicles, one goes to single digit, they go on Monday. They tried all means, but then there was a lot. So air quality index is more than 500 is considered hazardous. We are in a very safe zone. Right now we are at 2022 in Vadagara here today. So that's great to talk about, AQLI. Effects of outdoor pollutants on child health, adverse birth outcomes, even the infant mortality also, it has got a risk. We always talk about the respiratory illnesses only, but we must know that it rise to preterm birth and low birth weight. Even the maternal outcomes are also there. So it is not merely talk about respiratory infections, not merely talk about asthma. If you say the outdoor air pollutants has got their detrimental effect on every segment. You see, lung functions, ALRI, asthma, otitis media, childhood cancers, everywhere this has got its impact. But then they come slowly and indirectly. So we don't realize it, how fast. But for a respiratory infection, we realize it very fast on many situations. Preventive steps, outdoor pollution, is there anything we can do? Yes, less polluting fuels, that improves the fuel efficiency. Regular pollution level checking for vehicle certificates, it's happening, but it's not happening with the better vehicles. We see the trucks fuming out dust and particulate matter like anything, that big trucks. But even the cars and smaller vehicles, they maintain the pollution. They come under the pollution control agency. More on renewable energy sources. Solar and wind energy is being sought across the country, and our scientists are really giving a thought to the renewable energy sources. Across the globe, they are thinking about renewable energy sources because we are at the brink of global warming. The sea level is increasing by 0.4 millimeter every 5 years. It's a very bad scenario for our next generation. So we need to look at certain aspects where we can renewable air sources are there. Mass transit system, this is very important. There was a study where the Olympics was held in Atlanta, where they used that the city limits were blocked and only mass transit was entered into the city. So they used only public transport vehicles only, buses only, and no cars. So they were able to bring down the air quality index there, the pollution level by substantial levels by depending on mass transport, public transport systems rather than using the individual cars and vehicles. That is tried in Atlanta in the Olympics time. So there are many documented experiences in international files where we can bring down the outdoor pollution level by depending on certain measures like this. Even petrol vehicles, for that reason, they are less polluting than diesel vehicles. So wherever possible, we suggest use petrol vehicles. So indoor pollutants, that about outdoor pollutants, but as I suggested earlier, we have the role of advocacy only. We don't have we cannot do much directly from our side to prevent outdoor pollution. What about indoor pollutants? It is our own house. We can modify it. Our own den. We can just cultivate better habits inside. Let us see tobacco smoke, something which is easily avoidable. ETS exposure, single most important determinant of asthma in inner city population, and many a time the parents or they think about or the grandparent, mostly they are the generation who smokes have come down. The grandparents, they say about first hand smoking, but there is second hand smoking, and more important, third hand tobacco smoking is there. A grandparent who takes a cigarette or for that smoking outside and gets just before entering the house, he leaves the cigarette outside and enters the house, a small toddler get into his lap. The whole shirt and his clothes will be having some the animate particles from the tobacco smoke. So that itself is sufficient to produce some amount of respiratory infections or give rise to more respiratory issues in the child. So if at all he has to go, it is well noted that third hand tobacco smoke remains in the clothes of those the tobacco users for at least 1 or 2 hours. So whoever wants to smoke, they can leave the smoking maybe 1 or 2 hours before entering the house. So this is about third hand tobacco smoke. These are areas which are poorly understood by or easily forgotten for many reasons, by even they know they forget about it. So we must insist on the child with an asthma in a particular household, see that whether grandfather is smoking, your parent is smoking, he quits smoking at least 1 hour before entering the house. So that is called third hand tobacco smoke. So tobacco smoke has gone from first hand, second hand to third hand. That is about the environmental tobacco smoke exposure, particle size. And there is a very good studies, robust evidence has flowed in for this statement number 3. Developing fetus exposed to ETS via umbilical cord blood, baby's immune system was deviated to asthmatic and allergic phenotypes. The mothers who smoke or who are exposed to second-hand tobacco smoke, they have the babies, the immune system has developed to allergic phenotype, and that is more prone to develop asthma in future life. So biomass fuels again, particulate matter, carbon monoxide, sulfur dioxide, nitrogen dioxide, you can see the volcanoes, formaldehyde. Then again, at the inside the house, you are better always to use what you say the crude oil, the gas stoves for that reason, and not about the wood or firewood or other fuel as far as fuels. So benzene, this is, you see, the incense stick which you use for many a time in your prayer rooms or in the even what you say kundarikam in the many households, or the sambrani in the other many households. See how much is there. One stick incense, 25% herbal wood, 35% fragrant, 1% and 33% bamboo stick, and they produce a lot of particulate matter into the atmosphere. Mosquito coils, this is another important study because mosquito coils are mostly used in Chinese population, China, Vietnam, everywhere. And there are many studies which suggest that mosquito coils, burning of one mosquito coil will produce particulate matter to the time of 131 times that from the cigarette at the end of a cigarette. So you say particulate matter from cigarette, and 70 to 137 cigarettes, equivalent to burning of 70 to 137 cigarettes is one mosquito coil. But our poor population, poor rural household, they don't have other ways. But we must convince them in one single room, all of them will be, the father, mother, children will be lying down sleeping in the same room, one mosquito coil or 2 mosquito coils will be there on both sides. So see how much amount of particulate matter, how much amount of air pollution they are exposed to. Maybe they don't have other ways, but still we think about some alternate source, how they can be rescued, mosquito nets or other aspects, whether they can use it. So mosquito coils are one among the important indoor pollutants. Indoor allergens, after going from the indoor pollutants, indoor allergens, dust mite, cockroach, cat, dog and moles would be we can just quickly go through that. Dust mite, as you see, dust mite. This is, I always show my parents, I always bookmark this particular page of what you say dust mite. Tell them what is dust mite. You see this, just like a rhinoceros it is there. This is an electromicroscopic view of a dust mite. And once they see this, they are literally scared. Doctor, we are inhaling all these things. Yes, you are not inhaling one, you are inhaling 1 million. A pillow which has been used for 1 year carries more than 1 million dust mite. Pillow. because basically these dust mites, they thrive on the human dander. The skin is every time it is denuded from our surface, and the mosquito, the dust mites are very happy with the human dander. So they thrive on that. And pillows we don't wash. Pillows we don't take out. Bed sheets we wash. So pillows at least once in a month you have to take it outside, make it sun dry. Sun dry, don't dust it inside. Take it outside, sun dry. So these are all aerobiologicals. They die out once you take it outside into the sun. So this is important to take the pillows, and this is the mighty mite. You can see how in the electromicroscopic view of the dust dermatophago, pteronismus, farinae, mainae, all those aspects. So microscopic feeds on human scales and debris, SDM fecal pellets. They are actually the fecal pellets are the culprits, and major allergens are DER-P1, DER-P2 and DER-3. Dust mite preventive measures. Can we help? Says we can help, and I always, or we must talk more to the parents regarding the dust mites, what exactly we can help. We should be more realistic when we talk to them. We cannot take the beddings outside and sun dry, because the beddings are made for the quarter nowadays and made for the house. So we cannot take out the beddings outside, but we can take out the pillow once in a month. You can sun dry, wet mopping, regular vacuum cleaning, because now our parents clean our floor morning and evening, but they never look up because the dust mite is always in the fan. The fan leaves are not at all clean, at least once in 2 years. Many fan leaves, they have so much of dust. So at least it may be not be that easy to go to the height and clean it, but you can use vacuum cleaners, use it, and then see the all those the boxes and everything will be kept outside. So use minimum articles in the bedroom, minimum things. Don't keep your the clothing everything in an open side. You use a closed wardrobe and put it inside. Wherever there is a dead space, this dust mites will come and settle there. So give minimum space for the dust mites to settle. So that is regular vacuum cleaning. Mites thrive in humidity. So if we can bring down humidity, if you are using AC, because average humidity in Kerala is something around 80%, 80 to 85. So that's why we are having a high incidence of, I would say, dust mites and then the asthma for that reason. Maybe if you go to the UP, the average humidity is something around 40 to 45% or even less than 40. You don't set in UP, you don't set in MB, Madhya Pradesh, but you set for 5 minutes, you stand outside, start setting here. So humidity is more than 80%. So if you can bring down the humidity, that helps you. Wood and plastic furniture instead of leather and fabric. Avoid bedroom carpeting. Carpeting always adds to the finer finishes of the house, but then it is you have to pay a price for it. Carpets, the wooden carpets, sofa carpets and everything, they carry so much of dust. They give room and space for the dust mites to settle and grow. So you have to compromise balance. If you are using the carpets, see that you vacuum it at least once in a week. Otherwise, you don't, minimum of, especially if there is an allergy, ectopic child is in the family, ectopic parents are there. The parents are ectopic, child is ectopic, it is worth removing the carpets from the house. It always comes down the incidence of allergy by another 10%. Impermeable covers, pillows, mattresses, plastic or vinyl covers with zippers. You can see the picture there. At least you can have a zipper. You can cover the impermeable, because if there is a permeability somewhere, the dust mite will settle. But then sleeping over a plastic bed is very difficult because of hot climate, the humid sensation, it will be very bad. But then it is a balancing act. You have to balance both sides. Dry heat, exposed beddings and mattresses. I've got 5-10 minutes. Okay, I'm not sure of that. Not 4 minutes. Okay, fine. Thank you. Dry heat, exposed beddings and mattresses to direct sunlight for 5 or more hours. This is important. Take it outside and keep it in the sun, so that the dry heat, even ironing will be helpful. Wet heat, wash bed sheets, change linen at least twice weekly. In practice, patients and families may have difficulty in implementing a full dust mite regimen. Having said all those things, it is not even practicable in my house. And I am pretty sure our lady members will be wondering what they can do in their house. The carpets, no. The beddings, what to do. The pillows, what to do. And I have got to ask the atopic child. Sir has said all those things. Is it practical in my house? Okay, fine. You can do certain. Your full dust mite regimen may not be applicable, but still you can go about certain regimens, certain aspects. At least you can educate your parents and tell them, and if those who can comply with it, let them be benefited. That is what we can say. Partial implementation may not do, there are studies there. Cockroach, of course, our perennial friend, cockroach is out there, strongly linked to asthma in the inner cities, and 3 main species, Blattella and antigens are there. Saliva and fecal pellets of cockroach are the one culprits there. Sealing cracks in the flooring and walls, removing the old houses are good. They maintain the antique nature of the house, the ancestral houses. But whenever you modify and get your ancestral houses modified, see that it has minimum cracks in the walls and ceilings and regular extermination is there. Pet dander, $1 million question, whether you use good or bad to use the pets. I think Dr. Sukumaran can contribute. We have discussed, Dr. Paramesh and many forums we have discussed whether to have a pet, good or bad. But the current consensus is, it's good to have a pet in your house in the early infancy, in the first 1 year of life, which that exposure will stand good for you in the future. But exposure to pet animals in the later halves of life, maybe in the teenage, the toddler age may not be good. The males produce more cats. So which is more harmful, cat or dog? Cats. Cat's saliva is considered to be to stick on. What literature says is, if the cat is there, okay, fine, atopy, you want to get rid of the cat, you throw the cat outside, send it, and the cat will come back many ways, many a times. But the cat saliva will remain in the plastic or in the floorings for 6 months. Cat saliva for 6 months at least. So you cannot make changes on a fine morning. At least it takes 6 months for the cat saliva to be out. Cats more allergenic than dogs. Cat dander is found for 3 to 4 months. Dog dander less prevalent. They are not that harmful and they are always but the timing of exposure to pets seems critical. With prenatal or infancy exposure, protective effect on so a pregnant mother is good to be exposed to the cats or the pets. She can leave it to their pets and at least 1 year after. But many a times it is not easy to divorce the pets afterwards after 1 year. Till 1 year, having been with the pet for 1 year, they find it so difficult to be without the pets. Protective measures: removal of pet, no pets in bedroom, mattress covers, wash hands immediately. Molds, there are many molds out there. Optimum temperature, eliminate source of dampness, dehumidifiers, HEPA filters and change filters in AC regularly. Take home, air pollution a major determinant in child health. As you see, it's a major determinant, indirect determinant many a time. Outdoor pollutants, PM particulate matter, yes, sulfur dioxide, all are there, but particulate matter is the proxy indicator of air quality. Indoor pollutants, environmental tobacco smoke, biomass, mosquito coils and other aspects. Indoor allergens, house dust mite, the main thing, house dust mite, which is it's very difficult to contain the house dust mite. Cockroaches, pets, moles, and preventive measures. And of course, I've added something there, the feasibility. Preventive measures are easily said than done. It's not that easy. But indoor allergens, you can make a difference. You advise properly. Maybe certain people can stick to this certain how to modify the indoor allergens, their feasibility. So, friends, I believe I have just given a broad overview of air pollutants and how important they are. You all know about it. But how we can go about it in a realistic phase with our patients in our own life and with bettering the outcome of our children who suffer from allergy, asthma, other respiratory disorders. Thank you very much for your patient hearing, and once again my best wishes to IAP Vadagara, Environment and Child Health Chapter and the respiratory chapter of Indian Allergy chapter of Kerala State Branch Indian Academy of Pediatrics, and my best wishes to all the seniors. Thank you, Chairpersons.
Thank you. First of all, I'm thanking to Ramesh Kumar sir for the wonderful presentation. Sir discussed all aspects of the hazards of air pollution. In the current scenario, developing society, this topic is very important. Now the session is open for discussion.
Talcum powder. Talcum powder, of course, it's a particulate, it's a powder. And if the child is ectopic, if you can use it in a very, very limited setting, you cannot powder it and then use it spread and then use it. If you can, maybe the child, a small baby is here, you can go to the next room and do it. Per se, there are many things better if you can live without them, but these are things which we cannot live with them. Talcum powder not to use, how many people can go without it? So we have to live with it, but we have to see how best we can. It is not affecting your whoever it is, maybe the baby or the infant or small children in the house. Basically, this talcum powder is also something which can contribute to the environmental as an hazard, but it is not listed as a major hazard or anything.
Sir? Thank you, sir.
Yeah.
The session is over.
Okay. Now I would like to invite Dr. Faisal and Dr. Sajid D to hand over the memento of appreciation to Dr. Ramesh Kumar R. Thank you so much, sir, taking time out of your precious. Next, I would like to welcome Dr. Mrinal S. Pillai, Chief Neonatologist, SVT Hospital, Trivandrum, to the dais to hand over the memento to Dr. Faisal. Now, next, I would like to invite Dr. Jinsi, Cooperative Hospital, Senior Pediatrician, Vadagara, to the dais to hand over the memento to Dr. Sajid.
We welcome, Dr. Midun Premraj IAS to this program of PedLRICon. We welcome you, sir. Assistant Collector Kasaragod, he was the 13th rank in the IAS, the top ever topping from Kerala. He has been IAP regular at meetings, and I hope he has got some inspiration. He is here with us today. Midun Premraj, thank you for coming and gracing our occasion. It's great for us. And he's basically a doctor, taken MBBS from JIPMA and had his post-graduation diploma in public health from Public Health Institute of Procedures, New Delhi. And now he's here with us today. I request our National President, Dr. Ramesh Kumar, for a felicitation. I request Dr. Ramesh Kumar, our esteemed National President, to felicitate Midun Premraj, could say the wonder of Kerala. Thank you, Midun. A few words for IAP.
Respected dignitaries on and off the dais, a very good afternoon. When Dr. Prashant invited me over to this function, it was a really kind gesture, and I'm happy to be here. I'm sorry I could make it only in the afternoon. And more than I was lucky to attend the session because it was after a long time. And it's always a pleasure to go back to the subject that I studied or we studied. And something really new I learned about was dust mites. Despite all these years, I don't have much knowledge about them. And I feel it's also a subject that should be taught or made aware not just to doctors, but general public as well. Because it is a very omnipresent problem which affects almost all the people. Despite clashing with India-Pakistan World Cup T20 today, I'm really happy that I am able to attend this program. Thanks for all the love showered to me. Thank you.
Thank you, Midun. We have two good mementos also. One is environment-friendly bag made from pine tree. Another is lucky bamboo. So environment-friendly things. Thank you for coming. Thank you very much. Thank you. All the best. We are with you in all your endeavors.
I invite Dr. Nafil Abdul Majid, consultant pediatrician and allergist, NJ Skin and Hair Clinic, Trivandrum, for the talk on respiratory allergy, when to test, and how to choose allergy test. And my humble request to Dr. Muralidharan, senior pediatrician, past IAP president and past IMA vice president, Kerala, and Dr. Fazana, consultant pediatrician at Srichand Hospital, Kannur, to chair the sessions.
Good evening, all. At the outset, I would like to congratulate the organizers of this meeting, this conference, especially Dr. Hari Kumar, Dr. Jose, Dr. Vijay Kumar, Dr. Ramesh, Dr. Sukumaran sir, Dr. Prashant and Dr. Naushit for conducting this conference in an excellent manner. And for me, this kind of conference of the benefits of the conference are of twofold. One is you will get a wonderful chance to meet your old friends, colleagues, and respected teachers, and talk to them and with enjoy with them, and rekindle your thoughts or your memories of your younger days in a fantastic way. And it will re-energize you, and it will become a kind of rasayana chikitsa, and it will encourage you and energize you for a long time. And secondly, uh, the world of knowledge is moving fast in a wonderful pace. And if you are standing still at a point, the world will go beyond you, without you, and you will become a rip and winkle within a not time, within not time. So imbibing the present knowledge is very important, and this kind of conference will give you an opportunity to know what is happening around you. And now today we have Dr. Nafil Abdul Majid is with us, and he is a wonderful teacher, a great speaker, and his credentials I am not going to elaborate because it is showing here. And he is now working at a Lifeline Hospital, Adur, and he is going to talk about the respiratory allergies which we pediatrics are dealing with during the last 3 or 4 months in a alarming way. So I invite Dr. Nafil Abdul to speak about the subjects. Over to Dr. Nafil. Over to Dr. Nafil.
Good afternoon, everybody. Uh, after lunch, we are joined again, and my topic today is respiratory allergies when to test. So today, till now, what we have listened is about all about allergies, what all causes allergies, and all aspects about allergies and the treatment, skin aspects, everything. Now, today in my talk, I'll be talking more about normal pediatric practice. We come across a lot of patients who comes to us telling that ഡോക്ടറെ എന്നും നിങ്ങളുടെ അടുത്ത് കുഞ്ഞിനെ കൊണ്ടുവരുവാണ്, ഒരു വ്യത്യാസവും ഇല്ല, റിപ്പീറ്റഡ്ലി അവൻ അസുഖം വരുവാണ്, എന്തൊക്കെയാണ് നിർത്തേണ്ടത്, ഈ ഫുഡ് നിർത്തണോ ആ ഫുഡ് നിർത്തണോ, എനിക്ക് കുഞ്ഞിനെ ടെസ്റ്റ് ചെയ്യണം, എന്താണ് ടെസ്റ്റ് ചെയ്യേണ്ടത്, ബ്ലഡ് ടെസ്റ്റ് ഉണ്ടോ, അലർജി ടെസ്റ്റ് ഉണ്ടോ. സി ഇൻവേരിയബിളി മെനി ഓഫ് ദ പേഷ്യൻസ് ഹു കംസ് ടു us wants to get tested. So who are the candidates adequate to be tested? That's what we'll discuss today. We won't be discussing anything in detail. We'll be going superficially because of short of time, and we'll start. So the need for this topic is because like we come across a lot of patients. I told you earlier that needs testing. Who all to test? What are the relevant tests we can do? And different tests available right now in India, and application of each test will be going across two case scenarios, short ones and the conclusion. And we know the incidence of allergies which was discussed earlier. I'll skip on. In India, we have a huge variation of symptoms. Like we take up in Kerala, and Narmada madam is there. Like in Tamil Nadu, in Kerala, we come across a lot of dust mite cases, cockroach cases, All these things are causing major allergens are dust mites, cockroach and fungus or molds. But when you go in Tamil Nadu, in Karnataka and all, there is a huge variation. The dust mite incidence is less and pollens is more. So like that, in India, the diversification of the symptoms is more, that everywhere the symptoms is different, the allergens causing the disease is different. So the testing we do here, there all varies. And there is, on the basis of the test, we have to stratify the patient on the risk, and we have to characterize the disease also. And phenotypic clustering we are not doing, because any asthma patients we are just starting them on inhalers and we are trying to continue it, and we are not going beyond that. So we need, there is something called as eosinophilic asthma and there is something called as neutrophilic asthma, which I will be coming later. So based on that, this is how we phenotypically cluster the patient. If the patient is neutrophilic, is not going to do well with our inhaled corticosteroids or our normal conventional inhalers. So how to do that, that also will come in this presentation. And what are the types of tests currently available? This is stage 1 of the presentation. This is what we normally do, that is a complete blood count. We have the total IgE. Everybody does that for allergy testing. We have absolute eosinophil count, sputum eosinophilia, then comes the allergy specific test. So complete blood count, not much of value for allergy perspective, just that it says if the patient is having any acute infection, and if the patient is having any primary immunodeficiency disorder, we will come to know about that. And in complete blood count, we also come to know about the eosinophil count, that I will be stressing upon on absolute eosinophil count when I speak. And coming to total IgE, so other than that, in allergy perspective, there is no much role for total complete blood counts. And in total IgE as a whole, total IgE as pediatricians, you don't have much role. Please don't do it for all the patients, unless and until, because we have elevated total IgE in many normal conditions like helmintic infections, CMV infections, other viral infections, environmental diesel smoke. All these patients will be having exposure to all these things, will be having, the patients will be having higher total IgE. So you won't be able to classify directly by doing a total IgE in a normal patient, standalone total IgE. In conjunction with other eosinophil, absolute eosinophil count and all, we can have more value for, add the value of total IgE. Other than that, it's not. Absolute eosinophil count, yes, I told you there is something called as eosinophilic asthma and neutrophilic asthma, which that is called as a phenotypic classification of asthma. In that, if the patient is having higher eosinophil count, then we can classify that it is more probably the patient will be suffering from a eosinophil type of inflammation. So that he is going to be more likely get improved with our inhaled corticosteroids. But that correlates with the absolute eosinophil count. But seeing the neutrophil count, you can't classify the patient as neutrophilic asthma. And sputum eosinophil, we don't do it routinely in children. Total IgE I have told already. And now comes the question that the mother asks you, like after doing all these normal blood counts, the mother asks you like, what can I do, stop to do the recurrence? What will it continue in future? How long to give inhalers? If will my next child will be getting affected? What are the foods to be given to the child? This food I give. Many of the children, many of the patient invariably comes and tells us that after giving milk, my child is having cough, so I am stopping milk. I am not giving milk. So this is one question you all will come across in your daily practice. That is not the case for respiratory allergies. And what are the tests we have now? After I told you about the normal blood counts and all, now we are going on to the specific allergy test. That is, one, we have allergy skin testing. We have serum specific IgE. We have component resolved diagnosis. It's a new thing. We have pulmonary function tests, in that we have spirometry, impulse oscillometry, peak flow meters, and we have, after that, for phenotypic classification, we have pheno, basophil stimulation test and patch test, which are all not done routinely. So coming to the first case, we have 5-year-old child visits the clinic, had been hospitalized for bronchiolitis at 3 months of age. Mother remember the child has skin issues too, that is the child is having atopic dermatitis. Since then, the child had recurrent visits to hospital for weeks, started on inhalers by the age 1, but continued to have exacerbations. She appeared to be controlled for 1 year at the age of 3, and now she comes with complaints of sneezing in early morning and running nose. On examination, she has allergic shyness and she is continuously doing allergic salute. So what is the case? Anybody? After lunch, everybody is sleeping. So, huh? So it's a early onset asthma, sir. So early onset persistent asthma with allergic rhinitis with atopic dermatitis. So the child is going through atopic march, we can say. So what is the next step as a pediatrician? We have done all the blood tests, everything. Now the mother is coming and asking you like, what else I can do to prove that my child is allergic or he is not allergic? How can we prove it? Any inputs? Normal things has been done. Counts, everything has been done. Any inputs? So this is the time we can tell them that uh, the child can go for allergic skin test. This is nothing but take on the basis of history. We are trying to show that the child is sensitive to some or the other allergens possibly present in that conditions. So we can identify the sensitizers. Always remember your allergy skin test will identify not allergy but sensitization only it identifies. It does not involve any blood or lab. It has a good clinical correlation and it is cost effective. So how to do the test, I'll show you. Just introduce on the volar aspect of the forearm. We'll just introduce how many allergens we need. There is adequate gapping, standardization, everything. We'll first put the negative control, then the positive control, that is for standardization. Then we do the test. We'll prick each allergens and we'll wait for 15 minutes. Then we take the readings. How much erythema is there, everything we'll take. And then based on that, based on the history, we try to interpret the test. And it is epicutaneous, it is not painful. We can start doing it from 2 years. Probably many pediatricians, allergists are doing from 1 year of age. On the back, they are doing. And older children, we can do it on the forearm. So this is how the test is being done. So which all allergy panel to choose? Everything based on the history. If the child is having, everybody says that there are tests, there are places where 200, 300 tests being done on a single setting. It's completely wrong. Based on the history, we do adequately 20 to 40 tests we do. That will be enough. So everything will be based on the history. So we have, based on the history, we see dust mite, cockroach and all will be done if the patient is having only indoor symptoms. And pollens and all will be doing if the patient is having outdoor seasonal symptoms. And if they are giving clear-cut history of food allergy, then we go for the food panel based on their history. And if the patient is they are having pets, we'll go for pets. And if he's a like healthcare worker, we go for latex, everything. So this is the allergy skin testing format. So these are the test kits available in India. So what are the pitfalls for the test? Standardization of the allergens use. It's very difficult to get standardized allergens in India right now. We have Delhi based, we have Bombay based allergens. Now many companies are coming with standardized allergens in India like Thermo Fisher. Not yet available now. Earlier our Indian allergens are costing somewhere between a full panel of around 50 to 100 allergens will cost you around 20 to 30,000. Before it used to cost standardized allergens, each vial will cost you around 4,000 to 5,000. That will be close to 1.5 to 2 lakhs for a complete allergen kit. And coming to, this is a case which we have told earlier about is like for the allergic skin testing. Now coming to a patient where allergic skin testing is not possible. So this is the condition. Rahul is a 2-year-old child, attended a birthday party yesterday where he has been given a cake. Shortly afterwards, he developed mild cough, developed sneezing, had swelling of lips and rash over the chest. By the time he was in the hospital, he had full-blown wheeze, treated with nebulizers, adrenaline and steroids. His father is asthmatic. Rahul has been on antihistamines due to itching rash all over the body with persistent cold. On examination, he had widespread eczema with rhinorrhea. So, which is this case? Any diagnosis? The child has been given adrenaline, nebulizers and steroids. He had full-blown wheeze. So this is a case of anaphylaxis, probably. So this case, Also, we wanted to do like they have been given cake on a birthday party. After that, within 2 hours, he developed all the symptoms. So it is an Ig mediated allergy. We know that, and we know the probable culprit may be something from the cake. How to test? How to prove it? So same thing like which we have told earlier, we can do a skin prick test, but this is not possible in a child because he is having widespread eczema and there is no free space to do test for us. So what we'll do in this child? There is something called as serum specific IgE. Total IgE is entirely different. In total IgE, you are just seeing how much IgE is elevated in the blood. The specific IgE is if you want to test for egg, you have specific IgE. If you are positive for egg allergen, you have probable sensitization for egg. We'll see the IgE bound to egg separately. Only that specific, that is called as serum specific IgE. We have different methods to do specific IgE. We have RAST, we have Immunocap, we have Imulite, and we have HITECH. Nowadays, before we were using RAST, now we are using Immunocap and Imulite. You have in Immunocap also, it is well validated. In Immunocap, you have two types. You have singleplex and you have multiplex. In multiplex, you can do in a single allergy testing, you can do 112 chips, like 112 allergens you can identify. So it is you where all this our skin prick testing is not possible, you can go for serum specific IgE. This is the blood test for allergy testing, and where skin prick test is not possible in allergic atopic dermatitis or severe eczema, and SPT skin prick test requires training, and you need to procure your allergens, standardized allergens, which is very difficult to available nowadays for getting the skin prick test done. And there is cross reactivity also. We have to take adequate history because you do 50 tests in a patient, almost 5 to 10 will come positive for everybody. So you have to clinically correlate based on the history which all is relevant for that patient and not. This is our job actually. So that requires adequate training and experience. This is the sample report. In this report, you can even quantify like how much is the serum specific IgE is elevated. This is how the report comes. So in our case, Rahul was found to be sensitized to egg and peanuts. His mom immediately asked if he developed anaphylaxis every time like now. Also, she wants to know, want to be sure about the preventive measures. Do we have an answer? We have found out now. Now she is asking, every time if he takes, will he go for anaphylaxis or full-blown wheeze, or it will be like this? How to prognosticate this case? We have done skin prick test, we have discussed about the serum specific IgE, how to find out where skin prick test is not possible. Now they are asking us, after this serum specific IgE, we have found out the child is allergic to this and that. Now, will he develop the same symptoms every time or not? That is clinical correlation. Will it develop? How are we going to answer this patient? So there is something called as component resolved diagnosis. This is the most modern thing which is available. I told you in serum specific IgE, you're checking if you are allergic to egg. You're seeing specific IgE bound to egg. That is, you are allergic to, your sensitization is more for egg or not, and how much it is quantified. That's it. But in component resolved diagnosis, in egg, in each allergen component, if you take peanut, you have major and minor components of allergies. So each component you can test with this component resolved diagnosis. This is the good thing about component. You see this is peanut. You have this red one RH9 and RH1, H2, H6, H7. These are all major components of allergens. Each have different implications. Some will last for long. Some will, the patient may outgrow, not in peanut. Other cases, the patient may outgrow. So this each component can be tested with component resolved diagnosis. It's not very expensive right now. Each component costs around 2000 to 2500, and multiplex also is available for many, around 250 to 300 can be done at a cost of around 15,000, which is available in two research centers in India. One is in Chennai and another is in Hyderabad. Not available on any labs. This is called as component resolved diagnosis. What is the use of this? As an allergist, we'll come to know that if this component is positive, the patient may outgrow. We can tell them that will he outgrow or not, we can tell them. And we can tell them whether any treatment is available or not, and whether every time he'll go for this reaction or not. That is to prognosticate the disease, we can do component result diagnosis. This is the most modern ultimate test which is available time right now. So I told you about immunocap. We have multiplex assays like this. This is a singleplex immunocap which I told you. This is the multiplex. The sense is the error code is like more because this is a more of a manual test. The multiplex assay, it's a chip and we have to manually put the serum. So what is the difference between in vivo and in vitro? That is blood and the skin prick test. What is the difference is in skin prick test, just remember this, that the patient bystander is just visualizing his or her allergen like component directly. So if he is positive to egg or milk, there'll be better understanding is there. They won't take it for their lifetime. It's very easy for us to show them and it's very easy for them to understand. And it's easy for us to make them understand also. And with a quality standardized allergen, doing a SPT with a good clinical history is gold standard in allergy testing. So this is, I told you earlier, the major and minor components. All these components can be found out with component result diagnosis. And there is something called as cross reactivity. You just see dust mite, which Ramesh sir was telling. Dust mite, it tends to cross react with many other components like cockroach, with seafood like prawns and all. So when we do allergy testing, everything will come positive. So we have to know, as an allergist and a pediatrician, we have to know the cross reactivity between each and everything so that we can clinically correlate. All these things can be found out with component result diagnosis. So with CRT, we can precisely diagnose allergies. We can decode polysensitizations. Polysensitization means the patient is allergic. They'll be coming and telling us they are sensitized to the child is taking any food. The child is getting allergic. So we can just pinpoint by doing the component result diagnosis. It also helps in treatment. Whether we want to start immunotherapy for a patient, we can do CRD and we can point out. And which all things to prevent, then that also we can find out from this. Coming to the next part, that is pulmonary function test. I'll just everybody knows about spirometry. This is so how much time I have? 10 more minutes. Okay. See, now we have done the blood and allergy skin test. Now we have to know the anatomical part. That is, the child is having respiratory allergy. What is happening inside his lungs? So for that, the best test and simple one which is available is spirometry. Again telling you, spirometry less than 5 years is a nightmare. Doing it is making a good quality, making a patient do a good quality spirometry test is very difficult. Less than 5 years. More than 5 years, okay, with adequate measures, telling them so much of counseling, we'll get a test, but it is actually very good to find out any airway obstruction, restrictive lung disease, find out diffusion defects and respiratory muscle weakness. We have, other than this conventional PFT like spirometry, which is a lab attended test, we have bedside investigations like peak flow meter, which is very easy to see the adequate response of our therapy. Again, we have something called as oscillometry and pheno, which is not covered in today's topic. This oscillometry is for any patient, you can do that, because in a spirometry you need a full tidal breathing, full forced breathing. It is very difficult to completely for a child to complete the curve, inspiratory and expiratory curve. But in an impulse oscillometry, just tidal breathing is enough, so that we can find out all the anatomical defects in the lungs. And in pheno is just fractional exhale nitric oxide test. This is to find out whether the child is having any eosinophilic or neutrophilic type of, that is to phenotypically assess what asthma he has, what type of inflammation the child has. This is about spirometry, everybody knows about this. No absolute contraindications is there. And three things, that is, we have to see for the forced vital capacity, FEV1 and the ratio of FEV1 by FVC. And one more thing is your FEF 25 to 75%. This is just for see whether the child is having any small airway obstruction or not. I'll come back. So after doing a spirometry, we need to make the child do a full curve. The child should get this much full curve, and based on these two curves and the values, we'll find out whether the child is having normal, obstructive, restrictive or mixed pattern. And after performing the spirometry, we have to show them the bronchodilator reversibility test. That is to show that the child is having reversible airway obstruction. So SABA should be stopped 4 hours prior to the test and LABA should be stopped 12 hours prior to the test. And any test with more than 12% of variability, we can tell them it is a bronchodilator reversibility. So this is something called a peak flow meter. It's a bedside test to assess airway obstruction. The child is made to blow. One full blow is enough. You have to make them do three best tests, and the best of the three is taken as the reading. So based on that, we have based on the height and age of the child, we have the chart, and we have to plot the chart every day. This is a housemate, like they can do it in the house only, and they can fill it up in the asthma treatment action plan. And this shows the variability of our peak flow meter on daytime, that is morning and night. Night it will be better, and morning it will be there. And here you see. Here you see like this is the morning reading, this is the night reading, and it goes on like this. Here the preventer therapy they have started. From this also improved. The child drastically improved. That then also the problem is morning and night variation will be there. That is physiological variation, but variation will be less compared to the child not getting any preventer therapy. So now coming to the last part of my talk, clinical relevance of investigating respiratory allergies. The patient will come to know if the child continue to wheeze or not. We can just prognosticate how the child will develop this disease later. Then in order to counsel and manage this child, assessment for risk factors of ongoing persistent asthma, detailed history and physical testing for allergic sensitization pulmonary function is mandatory. The take home message is it's the main thing in our respiratory allergy testing is everybody will comes to us. I get patients coming with us with a 5-page report telling they have done for around 400 allergy tests. They have done somewhere in the newspaper. They have seen an ad and they have done the test. Now what to do? They are coming and asking. So in that patients, like it's very difficult to counsel them and tell them like this is it's a humbug test. It's no use because they have used a outdated test with actually they are telling that they are doing serum specific IgE, but it's not the case. It's the older method of RAS they are doing and bringing. It's complete test they have done for 3000, that is 300 allergens. Normally 300 to 400 allergens will cost around somewhere between 10 to 15,000 if you are doing a good quality test. See, doing a 300 waste test, it's doing one test with a quality allergen or one test in a quality method, that is enough based on the history. If the child is having a history of allergy to milk or history of allergy to egg, just do that only. Don't just do all the 300, 400 tests. In that 50 or 60 will come at positive. Many of the patients will come to us with telling that tomato they are positive, pineapple they are positive. They're having itching after taking it. It's just the chemical effect which is causing the itching. It's not the proper allergy. So there is something called a CRD. This is the part of the take home message. That is CRD is something there that is for each major component in if you're taking gluten, that is if you're taking wheat, if the patient is having allergy to wheat, you don't know whether the patient is allergic to wheat or atta or maida. So that also we can find out with this CRDs. Exact thing with exact culprit of the allergy can be found out with the competent result diagnosis that is there. And spirometry and peak flow meter are essential to aid the diagnosis and follow up for asthmatic children. Thank you. Any doubts in this allergy testing and all, you can just ask because I was just rushing up because of short of time. So, sir, that I told you, no, like IgE doing IgE alone, you are asking, no. It's there in hyper IgE. It's a this thing. It's not in allergy perspective. I'm telling you. In primary immunodeficiency, you can do it. Because like sir, everybody is doing IgE invariably for all the patients. And the patient is coming with 2000, 3000 report. That is not relevant for us. as allergists to, it's very difficult to make them understand. Then asking why they are again doing it. Any other doubt? Actually, sir, the problem is now we are treating all the patients as eosinophilic, right? Eosinophilic, right? Allergy, IgE, eosinophilic. This is what we are considering. Now the school of thought has changed. There is something called as the child can get eosinophilic or neutrophilic. The child can start as eosinophilic, can move on to neutrophilic, or reverse also, and it can be a mixed pattern also. So if the child is having a neutrophilic airway inflammation, he is probably not going to get improved with a normal conventional corticosteroids. So that is the time where we consider biologicals or any advanced treatment. So when you consider for biologicals, you need your absolute eosinophil count. The categorization, you have omalizumab, you have dupilumab, you have mepolizumab, so many components are there. On base of total IgE and absolute eosinophil count and the symptom score, we try to give different biologicals. So there, the IgE, that school of thought has to be there for any person doing IgE.
These are one of the biomarkers which we use along with the like absolute eosinophil count, IgE count, CBCs we take. Then we take the allergy skin testing. We put all together, and the phenotypic approach is it should be the way we are approaching, not like giving steroids for every child. That's the.
Thank you, Dr. Nafil, for the precise and enlightening session. And indeed, this is a need of the hour for all of us pediatricians gathered here, because during this post-COVID period of recurrent respiratory tract infections, most of us are encountering concerns from parents regarding the need for allergy testing. So this was an enlightening session. Thank you. Thank you so much for clarifying.
Dr. Nafil, the experience was wonderful. Actually, you touched all the nook and corners of the subjects, and for us, it is the voyage through an uncharted sea of knowledge. Congratulations.
Thank you, sir. Thank you.
Thank you, sir. I request the chairpersons, Dr. Muralidharan and Dr. Farzana, to present the token of gratitude to Dr. Nafil Abdul Majid. I invite Dr. Shinod, Consultant Pediatrician, Kerala Health Services, Nathapuram, former Secretary, IAP Vadagara, to hand over the memento to Dr. Muralidharan. I invite Dr. Rakesh Raju, Secretary, IMA Vadagara, past Secretary, IAP Vadagara, to hand over the memento to Dr. Farzana.
We go on to the short talks next 10 minutes, short session 2. So, first talk.
Let's move on to the next topic, net zero. I would like to invite Dr. Harikumar Ji, Chairperson ECHG Kerala, Senior Consultant Pediatrician, Aravinda Hospital, Ponkundam, on the stage. And also welcome Dr. Rakesh Raju, Secretary, IMA Vadagara, now working at Government Health Service.
We have an eminent speaker today, Dr. G. Harikumar sir, Senior Consultant Pediatrician, Aravinda Hospitals, Ponkundam, Kerala. Sir, the Chairperson of ECHG IAP Kerala State Branch, Past President Dermatology Chapter IAP Kerala State Branch, Past Secretary Nutrition Chapter IAP Kerala State Branch, Joint Secretary Hospital Board of India IMA Kerala State Branch. Over to you, sir.
Thank you. I know late hours, people are waiting for the final bell. Uh, I assure you shall be precise in my talk. So this is a comparatively newer topic, that is net zero. Net zero simply means that cutting greenhouse gas emissions to as close to zero as possible. Greenhouse gases are carbon dioxide, nitrous oxide, methane, and water vapor, and fluorocarbons. So cutting greenhouse gas emissions to as close as to zero as possible means, and the remaining emissions absorbed by oceans and forests. Oceans and forests are called carbon sinks. So a greenhouse gas is any gaseous compound in the atmosphere that is capable of absorbing infrared radiation, thereby trapping and holding heat in the atmosphere. So these greenhouse gases are basically these are the culprits which leads to global warming and global warming. The natural and the human are the sources, the carbon dioxide, water vapors, nitric oxide, it is not nitric oxide, it is nitrous oxide, and methane are important GHs and are present in nature. Natural sources, carbon dioxide, respiration and natural fires, volcanic eruptions. So, all these produce a lot of carbon emissions into the atmosphere, and these carbon emissions are has to be cut short. No, net zero means net vala enna arthathil thaneyana. So bring this carbon emissions near to zero. So net zero to be achieved by 2050. So methane is emitted by natural wetlands, livestock, decomposition of dead plants and animals. Nitrous oxide emissions are nitrogen circulating among atmosphere, plants and animals and microorganisms, occur naturally through many sources associated with the nitrogen cycle. So how to achieve net zero? It is one of the greatest challenges, needs complete transformation how we produce, consume and move about. So that means most of the carbon dioxide emissions, carbon emissions are come from industries like coal industry, oil and gas industry, other big factories, and all these produce lot of carbon dioxide and other carbon emissions. So energy source consists 3/4 of green gas emissions today. So these sources like coal industry, oil and gas industry, and other big, huge factories, all these produce lot of greenhouse gases. So we have to cut short these gases, and for that we have to replace them. Replace these polluting coal, gas, and oil gas fired power with natural resources like wind and solar is the key. So this is a congested and busy slide which shows the effect of greenhouse gases on health and health of children. We will skip this. This climate change, extreme weather, altered rainfall, like dry, raised temperature, seal, right, acidification of oceans. All these are direct effects of all these are temperature changes, precipitation and floods. Wet becomes more wetter, dry becomes more drier. So droughts and wildfires, all these causes this greenhouse gas effects. So in the indirect effects are ecosystem disruption, changing vector pattern, air pollution and all. Increased risk of diseases, food insecurity, because we know malaria, diarrheal diseases and all that may cause food insecurity and malnutrition, educational attainment, forced migration, toxic. These all are long-term effects of greenhouse gas effect or global warming. Health effects are direct mortality and morbidity from extreme weather events, infectious disease, vector-borne, water and foodborne. All these, we know all these basic things. So, changing climate, extreme weather conditions, rising sea levels, water and food insecurity, heat stress, emerging infectious diseases, and large-scale population migration. Indoor and outdoor pollution, Dr. Ramesh had described in detail. So, I am not going into details. Increased respiratory problems, increases the risk of cardio obesity, type 2 diabetes, and metabolic syndrome across the child's lifespan. So, malaria, dengue, all these cause these weather changes, climate changes can cause all these diseases. The net effect of climate change, intensified malarial transmission across sub-Saharan Africa, could increase the malaria-related under 5 mortality by 10 to 15%. Climate variability, particularly average temperature change, is associated with a change of geographical distribution of dengue. So increase in diarrheal disease and parasitic infections, E. coli, Cryptosporidium, rotavirus, etc. So both low rainfall and high precipitation is associated with increased diarrheal diseases due to poor quality of drinking water. Exposure to air pollution during pregnancy increase risk of low birth weight, IUGR babies. Some studies suggest that higher average temperature increase the prevalence of birth defects. So all these are closely related to climate changes. There are also indications for a connection between extreme temperature and miscarriage and stillbirth. So high temperature, prolonged high carbon dioxide concentration, high precipitation increase pollen exposure and associated allergic disease. Warmer and more humid weather increase insects and contact allergies. So, as an individual, how can we contribute to net zero? The net zero is a concept that is put forward by WHO, and it means that the global warming should be bring back to pre-industrial era. Pre-industrial era means that after no pre-industrial era. Now it is around 1.1 degree and the global warming, and that it has to be below, it has to bring down to below 1.5 degrees centigrade. But if for that we have to cut short our carbon emissions from these energy sources to around 45% by 2030. But the reality is that if we go by this level, those our this global warming will increase, and around the carbon emissions will increase to 14 around 14% by 2030. But our aim and our goal is to bring net zero by 2050. So as an individual, how can we contribute to net zero? The UN set forth a few measures that can be taken by individuals in order to achieve the sustainable development goals. Donate what you don't use, waste less food, and support local farmers. So all these matters, all these facts were discussed by previous speakers. Waste less food and support local farmers. Get yourself and your family vaccinated. Help educate children in young community. Avoid wasting water, use energy efficient appliances, create job opportunities if applicable, support the marginalized and disadvantaged, use public transport or cycles, recycle. Dr. Narmada had touched upon that topic. They're using reuse, reusing and recycling. Avoid using plastic, plant trees around you, act now to stop global warming. So save electricity by turning off appliances when not in use and not energy friendly light bulbs. Turn off the light and take advantage of the natural light instead. Think before you print and recycle the paper you do use for printing. So we all know that whenever we use a book or a paper or so we lot of trees are cut for making newsprint. Actually, just recycle paper, plastic, glass, aluminum, whatever. Take shorter showers and save water. Responsible consumption and production. Don't overbuy. Plan meals and use shopping lists. Freeze fresh products and leftovers if you don't have the chance to use them before they go bad. Also, your takeaway food. Eat less meat, poultry, and fish. This sorts producing meat takes a lot more resources than producing plants. Buy and eat seasonal produce from local farmers or local growers. Donate what you don't use, clothes, books, furniture, food, whatever. By donating, you also contribute to other goals aiming towards no poverty, zero hunger, and reduced inequalities. Shop second-hand or trade clothes with colleagues, friends, or family. Use refillable water bottles and coffee cups. Use reusable cloth bags rather than plastic. So then about transportation, drive efficiently, regular vehicle maintenance, drive efficiently, drive less when possible. You can try carpooling or ride sharing to regular activities like work. Take public transportation like bus or trains instead of driving. Try walking or riding a bicycle. Shopping, reuse whenever possible. Repair instead of throwing. Donate so that it can be used to someone else. Recycle. And diet also, half of emission from food are from production of meat and animal, already told. And about EV, electrical vehicles in achieving net zero. So that is also a alternate mode of achieving net zero, decreasing carbon emission. No carbon dioxide emissions improves air condition. In our over a year, our electric car on the roads can save carbon emission equivalent to 4 return flights from Delhi to Bombay. Though car manufacturing uses lots of energy, electric cars are still greener because of reduction in emission over the car's lifetime. Reusing and recycling of car batteries also reduce carbon footprint. See, okay, that carbon footprint, what does it mean? The carbon footprint is the individual the contribution by each of us to the carbon emission. So in the carbon emission, that is so by our activities or anything by each person is knowingly or unknowingly contributing to the carbon emission. That is what is called carbon imprint, carbon print. So that is it, that is the end of the presentation. Thank you.
Thank you, sir, for enlightening us. A new topic, net zero. Now the topic is open for discussion. Any questions or queries?
If no doubts are there, okay,
The session is over.
now I would like to invite Dr. Rakesh Raju to hand over a moment of appreciation to Dr. Hari Kumar. Thank you, sir. Thank you. Now, I would like to invite Dr. Preena, Consultant Pulmonologist, PARCO Institute of Medical Science, to the dais to hand over memento to Dr. Rakesh Raju.
Thank you, sir. Our next topic is anaphylaxis by Dr. Johnny Sebastian, Consultant Pediatrician, Kerala Health Services, Kannur. Also, we welcome Dr. Anil Kumar, Consultant Pediatrician, PARCO Institute of Medical Sciences, to chair the session.
We have a topic anaphylaxis presented by Dr. Johnny Sebastian. Sir is a consultant pediatrician in Health Service Department, Government of Kerala. He is a secretary of IAP Kerala. He was the ECHG chairperson from 2018 to 19. And over to you, sir.
Good afternoon all. At the outset, let me thank the organizers, especially Dr. Bala sir, Dr. Hari sir, and Dr. Jose sir for giving me this opportunity to present this topic before this august audience. Actually, in the morning, most of the speakers have covered anaphylaxis, so we will just rush through this topic. So it's a very important topic, anaphylaxis. We'll start with a case. A 5-year-old child with history of bee sting half an hour back and came to the ED with itching all over the body, swelling over lips, difficulty in breathing, abdominal pain and nausea. On examination, the child was irritable with rashes all over the body, respiratory rate of 60 per minute and a pulse rate of 140 per minute, chest few bilateral bees. So the treatment was given at the emergency. Child was treated with injection hydrocortisone. Injection Avil was administered, salbutamol nebulizations and calamine lotion. Child was advised to keep in the for observation in the emergency room. While giving nebulization, child developed cardiovascular collapse. So what happened with this case, whether the diagnosis was right and whether the treatment given was right, that is the question. So with this we enter the anaphylaxis. So the definition of anaphylaxis: an acute clinical syndrome characterized by severe life-threatening generalized type 1 hypersensitivity reaction, usually caused by exposure to a foreign substance, leading to mast cell degranulation and release of chemical mediators. So, morning we have discussed the three criteria. Anaphylaxis is highly likely when any of the following three criteria are fulfilled. The first one is acute onset of an illness with involvement of the skin, mucosal tissue, or both, and at least one of the following, either respiratory compromise or circulatory compromise. The second one, two or more of the following that occur acutely after exposure to a likely allergen for that patient: involvement of the skin, respiratory compromise, circulatory compromise, persistent gastrointestinal symptoms. The third one, acutely followed after exposure to known allergen for that patient, reduced blood pressure defined as low systolic blood pressure for age more than 30% decreased in systolic blood pressure. So this is modified from the National Institute of Allergy and Infectious Disease and the criteria for diagnosis of anaphylaxis in the ED. Acute onset means within minutes to hours. Involvement of the skin includes generalized hives or urticaria, pruritus, flushing, swollen lips, tongue, uvula. Respiratory compromise includes dyspnea, wheeze, bronchospasm, low PER, stridor, hypoxemia. Circulatory compromise includes low BP or associated symptoms of end organ dysfunction like hypertonia, collapse, syncope, incontinence. GI symptoms: crampy abdominal pain, vomiting. Low systolic blood pressure for children is defined as less than 60 mm Hg from birth to 1 month, less than 70 from 1 month to 1 year, less than 70 plus 2 into age from 1 to 10 years, and less than 90 for 11 years and above. The causes, as we all are aware, it can be enteral ingestions like drugs, antibiotics, NSAIDs, aspirin, food. Parenteral administration: drugs, antibiotics, paralytic agents, opioids, propofol, insect bites and stings, contrast media, vaccines, blood products. Physical contact like latex also can happen. So the diagnosis: anaphylaxis is basically a clinical diagnosis and no lab parameters are required for diagnosis, and we should not wait for any lab diagnosis. However, the serial measurements of serum tryptase done at an acute stage and later can help to rule out systemic mastocytosis or pseudo anaphylaxis. So the main differential diagnosis what we face in practice is between syncope and anaphylaxis. Many of our practitioners we face this. So the onset in syncope usually at the time or soon after the injection due to that fear, anxiety. Anaphylaxis usually some delay happens between 5 to 30 minutes after the injection. The systemic skin, the skin will be pale, sweaty, cold and clammy in case of syncope, whereas in anaphylaxis it can be red, raised and itchy rash, swollen eyes, face. Respiratory, there will be normal and deep breaths, whereas in anaphylaxis there can be noisy breathing from airways, obstruction, wheeze or stridor. Cardiovascular, in syncope there can be bradycardia, with transient hypotension. In anaphylaxis, there is tachycardia and later on hypotension. Gastrointestinal nausea, vomiting can be present in syncope. Anaphylaxis, usually there can be same nausea as well as with abdominal cramps. Transient loss of consciousness relieved by supine posture in syncope. Anaphylaxis, loss of consciousness not relieved by supine posture. So the management algorithm, it is just adrenaline, adrenaline and adrenaline, and as soon as it's possible, we have to administer adrenaline. So initial management in the first 1 minute, you keep supine position, assess airway breathing circulation, provide oxygen, identify and remove the allergic trigger if possible, administer first dose of IM epinephrine as soon as possible at 0.01 mg per kg per dose. It is 1 mg per ml of 1 is to 1000 dilution. It's not undiluted and it is given IM. Always IM in anaphylaxis. And it can be repeated at 5 to 10 minutes interval as needed. And in 1 to 5 minutes again, you provide high flow oxygen by HFNC and plan for intubation. If stridor, first nebulized epinephrine is given at 0.5 ml per kg. If VC is present, first nebulized salbutamol at 0.15 mg per kg. Hypotension, poor perfusion, LOC. Again, IV or IO access to be established. First bolus of NS at 20 ml per kg is given by IV in case of hypotension. If it's no improvement, give the second dose of IM epinephrine. Can be repeated after 5 minutes. And for respiratory distress, again second nebulized epinephrine and second nebulized salbutamol is given. Again, if there is hypotension, poor perfusion and LOC, second bolus of normal saline at 20 ml per kg is given by rapid push technique and prepare for IV epinephrine. Alert the pediatric ICU or tertiary care center. In 10 to 20 minutes, if there is no improvement, you can give the last dose, third dose of IM epinephrine. And for respiratory distress, again, third nebulized epinephrine and third nebulized salbutamol and proceed for intubation. Hypotension, poor perfusion, loss of consciousness, if it's still persisting, start giving IV epinephrine at 0.05 microgram per kg per minute and titrate by 0.02 microgram per kg per minute up to the desired effect and transfer to the pediatric ICU. So if still there is no improvement, you have to suspect refractory analysis and start IV norepinephrine infusion. IV glucagon bolus also can be tried. So the management as per pediatric ICU protocols, delayed anaphylaxis may be due to biphasic reaction. So we have to monitor such patients who are having anaphylaxis immediate, that because there can be a biphasic reaction which generally occurs within the 1 to 72 hours, mostly within the first 10 hours, 8 to 10 hours. After the initial improvement, a protracted variety, which is the severe persistent anaphylactic symptoms, can happen despite aggressive treatment. Monitoring of vitals along with respiratory symptoms should be done every 5 minutes during the first 30 minutes and then hourly for the next 24 hours and then 2 hourly for the next 48 hours. Follow-up of patients should be done for at least 4 hours after last IM epinephrine injection in severe hospitalized cases for a minimum of 3 days. So this is adrenaline. So we have a EpiPen which is available abroad. Green color is 0.15 mg and yellow color is 0.3 mg injections. That is the ideal thing, but due to limited resources in India, home prepared IM epinephrine injection 0.01 mg per kg 1 is to 1000 dilution in 1 ml syringe may be a practical solution. It can be kept for 3 months at room temperature with protection from light. So you have in such cases, just 10 minutes. So just 2 minutes. So you need to know a state emergency number. The national emergency number is 112. So the last slide, the take home messages. Anaphylaxis is a sudden severe life threatening allergic reaction to an allergen with multi-system involvement. Early identification and management are the cornerstone in good outcome, because the first case they have not given adrenaline, they have given they have given nebulization, and by that time already the cardiovascular collapse had happened for that child. So it was actually not giving adrenaline was the major mistake. So IM epinephrine is the drug of choice. Follow up of patients for minimum of 3 days due to biphasic nature of anaphylaxis. Education of parents about its early recognition and appropriate management is a need of, especially during vaccinations, after, while sending children home. Everybody is nowadays should make them aware about any AEFI and all those things, and about the symptoms, so that they can recognize it early and appropriate management can be done. Usually in my practice, I think only once I've seen in my whole of my practice one case of anaphylaxis. So it's very rare, but if it happens, if you give adrenaline, we can save that child. And one second take home message which I feel is that if you are in doubt that whether it is an anaphylaxis or not, better to give adrenaline, so that there is nothing harmful to give one dose of adrenaline and save that child. Thank you. Thank you so much. Thank you.
Thank you, sir. That was a very enlightening presentation on anaphylaxis. This session is open for discussion.
Next, we invite Dr. Anukumar to hand over
Session is over.
a memento and certificate to Dr. Joni Sebastian. I humbly request Dr. Narmada Ashok, Consultant Pediatrician Vellore, to hand over a token of gratitude to Dr. Anukumar.
Now we will move on to our next topic, that is high time to make our conferences as environment friendly as possible. I would like to invite Dr. Balachandra, Senior Consultant Pediatrician, Kerala Health Services, Pathanamthitta, National Secretary, ECHG 2021-22, to the dais to handle the session. And I would also like to welcome Dr. P.C. Haridas, past President IAP Vadagara and President IMA Vadagara. Now he is currently working at Government Hospital, Talasheri.
Good evening to all. Our next topic is by Dr. Balandra. Everybody knows Dr. Balandra. He was the a past Kerala State IAP Secretary, and all details are given in the slide, and I am not going to repeat it. About the topic, Dr. Balandra will present about high time to make our conferences environmentally. And one of the major global concerns we are facing today is environmental pollution, which itself is a cause of various allergic manifestations for pediatric and adult population. Hence, it is very essential to make every event environment friendly. To enlighten this topic, we have an eminent speaker, Dr. Balendra. Over to you, Dr. Balendra.
Thank you, Haridas sir, for the introduction. First of all, let me thank the organizers for including this topic, even though it is high time, and Dr. Harikumar's presentation has made my job easier. Why these conferences have to be environment friendly, that Dr. Harikumar has explained. Just a pictorial representation that our environment is in health crisis. Just like our health, environment also is crisis is very much important, and we don't have a planet B. So we have to be like ECD champion, like early childhood development champion. We have to be environment champion. For that, Dr. Harikumar has explained everything. That is what is given as a pictorial representation. And plastics is the most important hazard now. That India stands 94th in the list of 100 single-use plastics generating countries, and India's net generation single-use plastic waste is around 5.6 million metric ton, and per capita generation is 4 kg. And that is why the Minister of Environment, Forest and Climate Change issued a gazette notification that ban on single-use plastic from this year, July 1st. And why this ban on these items? Plastic left in the environment for long turns into microplastics. Recently, there was an article that saying that plastics has been seen in the innerwear of ladies. So these babies, breastfed babies, are like to get plastic toxicity also. So that is so we just like I think Dr. Prashant was trying to make it plastic friendly, plastic free conference, and this carbon footprint of this conference, that also just when you organize a conference, these are all the things we have to look for: call for papers, program booklet, proceedings, additional printed materials, conference bag. All these produce carbon footprints. So this is this is the environment impact expressed in eco indicator points that call for purpose program. There you can see the nylon bags. That causes the maximum environmental impact. But here, Dr. Prashant Naushid has made it to jute bag, so that is solved. And these call paper presentations, that all these generate a lot of carbon dioxide. And is there any need for a change? Actually, there should be a need for a change. There is no point of question mark there. There should be a change. So for this, our Environment and Child Health Group has made some SOP this year on 13th of May, which was released during the World Women's Wing program through webinar by our National Chairperson Ramesh Vijania, and where Dr. Narmada was the coordinator. So the following are the recommendations to conduct an environment conference. That changes can be made in every possible situation. It's not possible to do 100% environment friendly. When I went through the criteria, I will bring in some 40 criteria. I think this conference, even though Prashant and Naushis made it environment friendly, they have achieved only 25%. And we have to see how Narmada is going to do next month at ID conference Vellore. So, but this is, it's very good because a small change by each one of us can go a long way in conserving. All of a sudden, we cannot make it 100% environment friendly. And starting with the first is the pre-event information. The use of paper for brochure registration forms can be done away with, which here our Prashant has done that. Everything should be made online. That also has been done. Information can be sent as WhatsApp messages, which will be included as flyer as well. That is also done. The wall and furniture paint decorations should be lead free. That is not in our hands. Inauguration should be done away with flowers. So potted plants with colored leaves can be used instead. But here I've seen a lot of, Prashant has said it's not possible because it's given to event managers. Paintings done by specially gifted children, individuals can be used as decoration. This was done by Dr. Jijo and his team at Pathanamthitta, where they gave handmade items made by gifted people, disabled, autistic children. So that can be, we can do that. Sapling plantation can be done as an inaugural procedure. That also can be done. Registrations, use green badge. Anyway, we have not used any badges here. That is good. Use recycled paper files instead of plastic. Here there is no, I think we have used only paper files. Use green pen inside portfolio. That has been done here, but we have been given another pen, sponsored pen. That also have to stop that. Scientific content by organizers as well as state may be made on websites. This is not a big conference for that. And conference kits and bags, totally 100%, they have made it environment friendly by using jute fiber. Gifts can be seed of plants. I think I've given to the assistant collector that a plant was given, that's good. Then delegates should be encouraged to have boarding travel passes on mobile, that is for big conferences. conference should be boldly advertised as environment friendly conferences. That is done or not? It is, I don't think it has been done. So, okay, okay. Yeah. Because I think Vellore there, in bold letters they have done that. Green sapling and seeds should be given as mementos, or Borosil metal water bottle can be used as delegate gift. That is also for big conferences. I think Narmada is giving that in her ID. So, but unfortunately our state conference is coming on the same date. Uh, Food counters, today I checked all the waste bins, there is not much waste. Everybody has used their food, so that's good. We should not make it an overcrowding. We should have multiple counters so that patient um, but actually there shouldn't be, when easily available people tend to take as much as needed. So we should not make much, should not make available. Food should be available from the time of event. They can, overstaying causes overeating. So make it lunchtime very short. Food should be marked as healthy and high calorie food. Junks can be replaced with nutritious food and fresh fruit, fresh local fruits. Coconut water, sugarcane juice, all this can be kept along with tea and coffee. Energy drinks and colas were not there good. Posters to be put that has to be for big conferences. Posters can be put saying that take only as much as you eat. Leftover food should be distributed to needy as soon as the meal time is over through an experienced agency. Garbage collectors should be there. That also for big conferences, there should be collectors and cleaning staff provided with green uniform, mask and gloves. Water should not be used in plastics. Here we can see a lot of plastics in front of Dr. Prasad. This is the picture. Bottle is there, but plastics also is there. So this is the, on the right side, last year at Noida, I saw in my hotel, at a time, in one floor, see how much bottles they have kept. And on the left side, that picture is of gastroenterology conference at Jaipur. This courtesy Dr. Alok Gupta. He has given that water dispensing through that. So we can dispense water through biodegradable containers, and recycled water should be used in for flushing and mopping. And here not much pharma, but if there is pharma, they have asked them to not use plastic banners, don't give paper flyers, don't give any article made of plastics. All wrappers and cartons should be segregated on site and disposed properly. All products should be displayed digitally, and no use of glossy paper. And greens on signages signifying the importance of conservation can be put up. Air pollution, no room spray or air fresheners can be used because it releases a lot of VOCs and it is hazardous to health. So we need pure air, clean air. Noise pollution, delegates in celebrity and music nights should be provided earbuds to minimize damage to hearing organs, and small children should be kept away from that also for other main conferences. So the question is, do we need a physical conference and itself? Definitely we need a physical conference, but that makes our physical conference make our relation with our colleagues better, and if at all you need, you should make it environment friendly. So to summarize, the pre-event information brochures and forms should be done away with. Conference, there is no need of any conference badges. The huge hazard, the conference kit bags and inventories associated with the same can be done away with. Water bottles should not be used. Food preparation and wastages, there should be less wastage, should be they put boards that we should not waste food. That should be there in all counters. And exhibition areas also, plastic should be banned. And fellowship with the music nights, I put question mark because I don't know everybody will agree or not. And Hari says Venda. So we will see next month at Kozhikode. So he who plants a tree plants a hope. And if you really think the environment is less important than the economy, try holding your breath while you count your money. Thank you. This is the summary of what Harumar has said in the picture. Everything is given in that picture. Thank you.
Thank you, Dr. Balan, for the practical methods to make the conferences environment and eco-friendly. Any questions regarding this? You can ask, please.
Actually, we could have done it this time. This thing is the flowers, flower arrangements, then these bottles were bought from us. I actually bought a steel bottle. So, and also we are planning to give in steel glass and water. Now that we had planned, this is the difference between. Okay. And food was served with paper cups. No wastage also, and no crowding.
How much it will come, that tag?
Actually, we had planned a bamboo, this thing is there in Irigan Craft Village. Then we put away with the badge because, yeah. One day conference like usually we don't do now. I'll send you the number of the Irigan Craft Village for your conference. Okay.
Thank you.
Thank you, sir. That was indeed an interesting session. Now I would like to invite Dr. P.C. Haridas to hand over memento to Dr. Balachandar. Thank you, sir. Now I request Dr. Vijay Kumar, State President IAP Kerala, to the dais to hand over memento to Dr. P.C. Haridas. Thank you, sir.
I invite Dr. Priya, Consultant Pediatrician, Kerala Health Services, Talsheri, for the talk on food allergy office practice. I welcome Dr. Shinoj, Pediatrician, Kerala Health Services, Nadhapuram, former Secretary, IAP Vadagara, to chair the section.
A pediatric allergy conference is incomplete without a talk on food allergy. To enlighten us on this topic, we have Dr. Priya P. Rajendran, who is my own senior colleague at Calicut Medical College. She has done in her diploma in allergy and asthma from prestigious CMC Vellore, and she is now working as a consultant pediatrician under Government Health Services in Kannur district. So I welcome Dr. Priya to speak about food allergy.
Good afternoon all. At the outset, I'd like to thank IAP Vadagara and PAI chapter and ECG group for giving me the opportunity to present the topic. I'm sure all of us have encountered cases of food allergy or the so-called food allergy, because many a time we see parents restricting a lot of food groups to patients, to their children, thinking that they are causing all the symptoms to the child. And as a result, the child will present to us with malnutrition, both micronutrient as well as macronutrient deficiencies. So, the topic of food allergy should be approached scientifically in order to prevent malnutrition as well as to decrease the psychological stress to the patient as well as to the family. So, there are a lot of terms, there are a lot of confusing terms actually. We hear a lot of terms like adverse food reactions, food allergy, food sensitivity, food intolerance, etc. So, we have to have a clear-cut idea what is which. So, adverse food reaction is any aberrant reaction after consumption of a food or a food additive. It can be either either immune mediated or non-immune mediated. The immune mediated adverse food reaction is otherwise known as the food allergy or the food hypersensitivity. It can either be IgE mediated or non-IgE mediated. The non-immune mediated adverse food reactions, typically known as the food intolerances, can be due to enzyme deficiencies, toxins, GI infections, etc. The commonest example being the lactose intolerance. This is a broad classification of the adverse food reactions. As I already told, there is immune mediated and non-immune mediated. And this immune mediated is again classified into IgE mediated and non-IgE mediated. And there is a mixed group, that is mixed IgE and non-IgE mediated. And there is a celiac disease which is T cell mediated. The food intolerances, that is a non-IgE mediated, may be due to enzyme deficiencies, pharmacological reasons, or merely it may be due to irritable bowel syndrome, etc. So what is food allergy? Food allergy is an adverse immune mediated response which occurs reproducibly on exposure to a given food and is absent during avoidance. It requires the evidence of sensitization, that is prior sensitization is needed. So that the sensitization can occur either orally through inhalation or transcutaneous route, and specific symptoms should be present on exposure to that particular food. Please note that this food allergy is completely different from food sensitivity. In food sensitivity, there is presence of specific IgE antibodies to the food, but the clinical symptoms will be usually absent. Whereas in food allergy, there will be clinical symptoms. Coming to the prevalence, food allergy can occur in any age group, but it is always more common in the younger children. In less than 3 years age group, the prevalence is 6 to 8%, and it is found to be more in boys. The male to female ratio is 5:1. In more than 8 years, the prevalence is 4%. Coming to adults, it is 1 to 2%, and it's more common in females. The ratio is 1:2. It is said that up to 6% of children experience food allergic reaction by the first 3 years of life. Coming to the Indian scenario, not much studies have been conducted in India, but this is a study conducted in Karnataka by Dr. Mahesh and team, where they intended to find out the prevalence of sensitization and probable food allergy to 24 common foods among the adults in the general population in Karnataka. What they found out was there was a high level of sensitization, that is 26% was observed for most of the foods studied, which was higher than that of the adults in Europe. But however, the prevalence of probable food allergy was only 1.2%, which was mainly accounted for cow's milk and apple. But the level of sensitization was higher than that of the counterparts in Europe. So it's always said that in any population, an increase in the food allergy usually occurs about a few decades after the increase in the respiratory allergies. So world over, the respiratory allergies increased in the 1960s, and now in the 2000, after 2000, there is an increase in the food allergies. So the food allergy is known to be a second wave of allergic diseases. So this may cause a potential allergic tsunami in the developing countries. In the developed countries like USA and Australia, there is a 300% increase in the peanut allergy and 500% increase in the food-induced anaphylaxis respectively. This is the mechanism of IgA-mediated food allergy. In the first exposure, that is in a genetically prone individual, when they consume a food, or the sensitization can either occur in the oral route or the inhaled route or the transcutaneous route. When the allergen first reaches the body, when the food is absorbed into the body and it is processed into the allergen or the protein, and this allergen is taken up by the dendritic cell. The antigen presenting cell takes up the antigen presenting cell takes up the allergen, and this allergen is presented to the T cells. At this point of time, T cells can either go to the Th1 pathway or the Th2 pathway, depending upon the prior sensitization. The Th1 pathway is the infective pathway, that is, it is against the infective bacteria and the protozoa. The Th2 pathway is the allergic pathway. Here, the Th2 pathway is activated, and this Th2 activates the B cells. The activated B cells produce a large number of IgE. This IgE circulates in the blood as well as it goes and binds to the mast cells. So, the mast cell bound, IgE is bound to the mast cell. Till this point of time, it is known as the sensitization. At this point of time, the patient is not having any allergic manifestations, but he is sensitized to the food allergen. On re-exposure to the allergen, that is when the patient consumes the allergen, the food the second time, what this allergen does is, it goes and binds to the IgE and causes cross-linking of the IgE bound to the mast cells, and this causes mast cell degranulation, resulting in the release of histamine, leukotrienes, tryptase, etc., which results in the reaction. So what are the common food allergens? Keep in mind that any food can cause food allergy. Food allergens are usually water-soluble glycopeptides, resistant to proteolytic enzymes, acid and heat. The common allergens that can be seen is the top 8, which you can see in the picture. That is milk, egg, peanuts, tree nuts, soy, wheat, fish and shellfish. These are the 8 top allergens that cause majority of the food allergy. The common allergens in children include milk, egg, soy, peanut and wheat, which constitute about 90% of the food allergens in children. The common food allergens in adults include shellfish, fish, peanuts and tree nuts. There are certain factors that contribute to the development of allergy, that is the genetic predisposition, maternal obesity with a BMI of more than 25 at a weight gain of 25 kg, more than 25 kg in the antenatal period, maternal exposure to nitrogen dioxide, soot, PM 2.5, diesel exhaust, etc., maternal smoking, increased hygiene and single child, that can be explained by the hygiene hypothesis, the presence of atopic dermatitis and asthma, all these contribute to the development of food allergy. On the contrary, maternal supplementation of vitamin D and folate and maternal microbial exposure, that is farming, etc., exclusive breastfeeding for a period of 6 months, increased diversity of complementary fruits in infancy and a large family size contributes to T-cell induction and development of oral tolerance. What are the clinical features? Usually the IgE mediated food allergy usually occurs, the reaction occurs within minutes of ingestion up to 2 hours. The skin is the most common target organ. Acute urticaria and angioedema the most common manifestations. Sometimes a biphasic reaction also develops, that is the symptoms develop after the resolution of the initial reaction without re-exposure to that food. Usually occurs within 4 to 6 hours to the food. As I told, the dermatological reactions, the skin is the target organ. Acute urticaria, flushing, angioedema, exacerbation of the existing eczema and mobiliform rash can occur. Local, oral or orbital manifestations include itching of the palate and lips, swelling of lips and tongue, eye itching, redness and watering and periorbital edema. Gastrointestinal symptoms include nausea, abdominal pain, vomiting and diarrhea. The respiratory symptoms usually occur along with the dermatological symptoms, but it can rarely occur in isolate, like nasal itching, rhinorrhea, nasal obstruction, sneezing, laryngospasm, dyspnea and wheezing. Systemic symptoms include hypotension and anaphylaxis. This is another interesting entity known as the oral allergy syndrome or the pollen food allergy syndrome. It is a contact urticaria actually. It's a localized IgE mediated food allergy. The patient won't be allergic to that particular food. However, due to similarity between the epitopes present in the fruits or vegetables and in common pollens, the patient develops allergic reaction while they consume the raw food. This is due to the highly homologous protein structure between the vegetables and fruits and the pollens. The symptoms usually affect the lips, mouth and throat, and there will be itching around the lips and mouth and swelling of the tongue, etc. Anaphylaxis has been reported in about 2% of the cases. This is the cross reactivity. The grass pollen, the patient who is sensitized to grass pollen can develop oral allergy syndrome too when they consume raw tomato, potato, carrot, etc. If he is sensitive to birch pollen, he can develop allergic reaction to walnut, apple, carrot, etc. So that is due to the cross reactivity. So whenever we deal with a case of food allergy, we should always keep in mind the clinical cross reactivity among the different food groups. There is 90% cross reactivity between the cow's milk and goat's milk, and 75% cross reaction between the shellfish and other fish. So this is due to more than 70% similarity in the protein structure, which causes the cross reactivity. So any person who is taking goat's milk for the first time in his life can develop allergic reaction because he is sensitive to cow's milk. The most dreaded complication of food allergic reaction is the food-induced anaphylaxis. The food is the most common trigger of anaphylaxis in children, adolescents, and young adults. It can occur by ingestion, skin contact, or inhalation of the minute food particles released during cooking. The mechanism, the anaphylaxis of food-induced anaphylaxis is slightly different from the anaphylaxis due to other reasons, because usually the mechanism of fatal reaction is respiratory arrest with isolated cardiovascular collapse, and gastrointestinal features are the more common in food anaphylaxis. Biphasic or protracted reactions are more common in food anaphylaxis, and when we have to identify, usually the other anaphylaxis is usually identified with the elevated serum tryptase levels, which is less commonly elevated in food anaphylaxis. This is yet another entity, that is food dependent exercise induced anaphylaxis, which is also IgE mediated. Here the symptoms occur after, while exercising within 2 hours after ingestion of food, or the food is ingested soon after the completion of exercise. Usually it occurs after consumption of food like shellfish and wheat. Other foods like tomatoes, cheese, peanuts, and celery has also been implicated. What happens here is the exercise reduces the threshold for anaphylaxis and increases the gut permeability. The cofactors that act in this case are NSAIDs, alcohol, and in females, in case of females, the menstruation. All these factors are present. If all these factors are present, they can act as a cofactor and increase the possibility of food-dependent exercise-induced anaphylaxis. The diagnosis is extremely challenging since prior food allergy may not be suspected, and the food challenge in the absence of exercise is usually negative. So the management includes avoidance of the food 2 hours before or immediately after the exercise, and anaphylaxis can be treated with epinephrine. So how will you approach a case of food allergy? The history is the most important thing. Onset, progression, and duration should be inquired, and a detailed examination should be conducted of all the systems. A symptom diary should be maintained. And tests include in vivo and in vitro test. In vivo tests include skin prick test and oral food challenge. In vitro tests include food specific IgE, component resolved diagnostics. So in the history, we have to ask for the specific trigger, onset of symptoms, that is within minutes or hours after the food ingestion, detailed description of all the symptoms, whether the patient had any concurrent illness, whether exercise was done prior to this, other food avoidance, last accidental exposure, previous medical history, like atopic dermatitis, asthma, and how well it is controlled, the medication history, epinephrine auto-injector, family history, whether the parents or siblings are having food allergy, social history, whether the child is attending daycare or school, whether the food allergy prevents from socializing and playing. A diet diary should be maintained. It is nothing but a chronological record of all the foods that a child has ingested and the symptoms that the child experiences. It should include what exactly the child has eaten and at what time of the day, number of servings, and specific ingredients if processed food is taken. This is the history in a prospective basis and is less dependent on the patient's or the parent's memory. It is very useful in finding the offending ingredient. It is also indirectly helpful in finding whether the child is getting adequate nutrition. This is skin prick test. I think it's already explained by Dr. Nafil. It is used to screen for suspected IgE mediated food allergy. Here what happens is we are introducing during the skin prick test, we are introducing the allergen to the mast cells in the dermis, and this causes a mast cell degranulation resulting in the reaction. All this I have already explained. The negative skin prick test is sensitive enough to rule out IgE mediated food allergy, IgE mediated allergy, because it has a high negative predictive value. In some cases, the commercially available antigens will be losing its potency after some time. So we can always use a prick on prick test. That is, the fresh antigens obtained by pricking the fruit or the vegetable is then used to prick the patient's skin. It yields more reliable results. This is an exhaustive list of the food allergens. Actually, from history and diet diary, we can cut short we can limit the number of allergens and use only those allergens, because most of these tests are expensive and we have to cut short the allergens. We have to be rational to the patient. Next, in vitro test is food specific IgE. This has also already been explained. It is used to detect the presence of circulating IgE antibodies to the suspected foods. This is the reference value. Next is the complaint resolved diagnosis. Dr. Nafil has already explained it. That is the patient's IgE, serum IgE sensitivity to the individual proteins rather than the whole antigen is checked here. But we have to keep in mind that these tests should be used only in context of clinical allergy. Without a history of suspected allergy, neither the skin prick test nor the specific IgE or the component resolved diagnostic should be used for screening the patients. We should always avoid bogus food allergy panel test. Then there is the oral food challenge, which is used for the definitive diagnosis of food allergy when history and testing are inconclusive. It is also used to determine the tolerance after elimination diet. In an oral food challenge, what is done is the offending food allergen is given to the patient in escalating doses. Initially 5 to 10% of the dose is given and gradually escalated in 20 minutes interval, and finally the whole dose of the food is given. The vitals and all systems are monitored. This should be performed only in a setting where the severe reactions can be treated. It is extremely useful in the diagnosis of adverse food reactions, both immunological as well as non-immunological. Young patients with suspected food allergy with low likelihood of reaction with a low level specific IgE and negative skin prick test can be good candidates for the oral food challenge. It can be either open, that is unmasked, unblended food is given to the patient, or it can be blinded, that is the food item is mixed with some masking vehicles like some spices or sugar, or placed in an opaque capsule. The gold standard of food allergy is testing is double blind placebo control challenge, that is both the patient as well as the examiner will be blinded to the food tested. So the treatment of food allergy, the appropriate identification and elimination of the responsible food is the only validated treatment for food allergy. The treatment of acute reaction is with only cutaneous reaction. You can treat it with H1 receptor antagonist, and anaphylaxis is treated with epinephrine IM 0.01 mg per kg. This is the adrenaline auto injector. This is available in not available in India actually. This is the learning material. Actually, the pen is there is a blue part and a orange part, and this is what they are taught is the blue to the sky and orange to the thigh. It is like a stab dose. However, in India it is not available, so we can always use epinephrine pre-filled syringes. And there is something called the allergen-specific immunotherapy. I'll finish it. The types of allergen-specific immunotherapy include subcutaneous, oral, or sublingual. There is administration of gradually increasing dose of allergens to which the patient is allergic, reaching a dose which effectively ameliorates the symptoms when the patient is re-exposed to the same allergen. The goal is to prevent anaphylaxis on accidental exposure to reintroduce the food in the regular diet. So what is the natural cause of food allergens? Most probably egg and milk, there is a high likelihood of resolution. In case of egg, 68% of the patients resolve the symptoms resolved by 16 years of age. In case of milk, 79% of the patients resolved by 16 years. In wheat and soy, 67% of patients resolved by 12 years of age. In case of peanuts and tree nuts, only 20 to 25% of the patients resolve. But in fish and shellfish, most of the times the allergy will be persistent. It has to be noted that extensively heated egg and milk is likely to be tolerated before cooked food or raw food or uncooked milk. It is because of the immunomodulatory benefit, and boiled peanuts are better tolerated than roasted peanuts. The food protein undergoes conformational change due to the high heat of cooking, rendering it to be non-allergic to some patients. Coming to prevention of food allergy, it can be a primary prevention, which is the best. It aims at the level even before the individual is sensitized, that is in utero. Secondary prevention aims at the sensitization level before the patient develops allergic reaction, and tertiary prevention is treatment of the allergic diseases to reduce its severity. The primary prevention includes maternal diet including vitamin D, polyunsaturated fatty acids, pre and probiotics, antioxidants, which has a low quality evidence. Maternal avoidance of allergic foods is no longer advised. Vaginal delivery and kangaroo mother care increases the exposure to maternal microbiota. Exclusive breastfeeding exposes the child to human milk microbiota. There is a LEAP study that is learning early about peanuts. It has changed the decade-old practice of avoiding highly allergic foods during weaning. It says that giving peanut powder regularly to infants as early as 4 to 6 months of age decreases their likelihood of peanut allergy in future. That is, it promotes oral tolerance. Other studies are also there which supports the use of cooked food, wheat, fish, sesame, etc. between 6 to 12 months of age. And food labels often there is it may be misleading because the because below a minimum amount the manufacturer need not list the content as an ingredient. So patient education should be important to identify the allergenic foods. And these are learning materials that are provided in the Western countries because they have a lot of psychological, because most of the children face a lot of psychological problems to the food, due to the food allergies. And there are certain cartoons regarding the food allergies to, in order to teach the children if they are having food allergies or if their friends are having food allergies. And these are the pictures of tiffin boxes where the labels are there saying that I have food allergy, please don't share food with me, because there are a lot of psychological issues because children can't attend parties or they can't share the food in their daycare, etc. And these are food allergies showing this child can't be given eggs and the other child can't be given dairy, etc. So the take home points, the food allergies are on the rise due to lifestyle changes. Proper history and diet diary is the most important. The skin prick test and specific IgE is used for confirmation. The best treatment is proper identification and elimination of the particular food item only. And IM epinephrine is the treatment of food-induced anaphylaxis. Exclusive breastfeeding should be continued up to 6 months of age, and it is the key to prevent allergic diseases. Allergenic food should be weaned between 6 to 12 months of age, that is, it should not be delayed. Thank you.
Thank you, Dr. Priya, for that brief description. And we are winding up this session due to time constraints. Thank you. The session is over.
Thank you, ma'am. That was a very informative session.
We have a guest, our pulmonologist, Dr. Preena. Madam, anything you want to add?
It's a very good session. Madam explained all corners of food allergy, including that food-dependent exercise-induced anaphylaxis also. I have one doubt. Madam mentioned about this difference between boiled and roasted peanuts. What's the mechanism in this difference between this boiled and roasted peanut allergy?
Yeah, actually, when we are boiling the peanuts, what happens is the low molecular weight proteins in the peanuts are getting released into the water, into the boiled water, and so this decreases the Ig binding. Whereas when the roasting, when we roast the peanuts, this Ig binding capacity of the peanuts increases. So roasting also, boiled peanuts are always less allergenic than the roasted peanuts. But I think most often people consume it because of the crunchy tastier, because the roasted peanuts are crunchier and tastier. Most often people now buy roasted peanuts, and that is the reason why there is an increase in the allergy to peanuts now.
Thank you, madam.
Thank you, ma'am. I invite Dr. Shinoj to hand over the token of gratitude to Dr. Priya. I request Dr. Preena ma'am, pulmonologist, PARCO Institute of Medical Sciences, to present the memento to Dr. Shinoj.
Hello, we move on to the last talk of the day, the last over. And Dr. Naushid will be taking strike, the last over. So anybody, we have missed the match today due to the conference. And so Naushid will be making after it and he'll be taking stage for the last talk.
Now I request Dr. Prashant sir to hand over a memento to Preena ma'am. Thank you, sir. Thank you, ma'am.
Let's move on to the last topic, fetal effect of pollution. I would like to invite Dr. Naushid Ani, Senior Consultant Neonatologist, PARCO Institute of Medical Science, Vadagara. And also welcome Dr. Mrinal Pillai, Chief Neonatologist at SVT Hospital, Trivandrum.
I think there is no need to introduce Naushid. He is quite famous here, quite active in IAP program and has a lot of publications. So over to you, Dr. Naushid.
Thank you, sir. I think everyone want to go from this hall, but before going, this is a very important topic. Today I am discussing about pollution on the fetus. Everyone knows about endosulfan tragedy in Kerala, mainly in Kasargod village. So many families are severely disabled in fetal effect due to the endosulfan effect. And in that, frogs, fishes, and colonies, so many jackals vanished from these areas. And what is a pollution? Already everyone knows. There is a changes in physical, chemical, and biological characters of air, water, and soil. This harmfully affecting our human life. The type of pollutions we know is land pollution, also known as the soil pollution, water pollution, noise pollution, and air pollution. Already we discussed air pollution effects to the child, but I am discussing the fetus effect. And already definition of air pollution we know, and I am skipping to other slide. In this slide describe about air quality index. Already we know the scale of the air quality index, and the northern state like Delhi, Noida, that's a bad air area. That's air pollution is more very bad there. In Kerala side, it is very good quality of air. That's why air quality index is very good in Kerala this side. And some source of air pollution, outdoor and indoor air pollution. That's a primary pollutants we can call carbon monoxide, nitric oxide, and the reaction happen in the air that leads to the secondary pollutants. And this is some pollutants routinely measured in ambient air: carbon monoxide, sulfur dioxide, and nitrogen dioxide, and ozones. And we can classify the pollutant particle into three coarse particle, that is particle matter size is 2.5 to 10 mics, and fine particles and ultra fine particles. The size is directly determine the particle potential for causing health problems. So smaller particle, those 10 micrograms in diameter or less being the more dangerous. And you can compare with the hair and the particle matter. The small around PM is 2.5, that particle is more high and dangerous, and this comparable size is we can compare with this fine beach sand. And some fetal effect of air pollution is it increase the inflammatory response of placenta and oxidative stress and placental dysfunction, and also it affect the genetic relation changes in the fetus and increase the epigenetic changes and systemic inflammatory increases that leads to the fetal effects. Basically, particular matters effects on fetus is preterm birth, IUGR, low birth weight, that means low birth, and infant mortality. And also, we can see the neural tube defects and other stillbirth is more in due to the air pollution. This is picture shows that the organogenesis affects the air pollution. Some timing of air pollution risk, you can see the heart defects happen in certain age, say, and preterm birth and reduced birth weight. So the air pollution is affecting heart and other limbs in organogenesis of the fetus. And the fetal effects of pollution is mainly preterm birth, stillbirth, and low birth weight babies, and congenital birth defect and congenital heart disease. And sometimes in child it makes autism and leukemia. Some studies supported for these fetal effects. And the adult disease also we can leads to this fetal exposure, like dioxin and furans could induce the delayed cancer, and chemical like DDT can reduce the growth rate and cardiovascular disease and later in diabetes. And this is, we know the tobacco smoke effect, like a risk of miscarriage will come in the fetus, and risk of preterm birth and low birth weight and sudden infant death syndrome, and risk of developing respiratory illness and risk of developing learning difficulties due to the smoking of we know about e-cigaretting. So many people are following the e-cigaretting, but in e-cigaretting also we have nicotine or tobacco effects that also leads to the fetal neurological and low birth weight and preterm delivery and sudden infant death syndrome. And one study shows that in pregnancy, when the air pollution happens, the higher infant mortality or lower birth weight and impaired lung development and increased respiratory morbidity in early alteration in the immune development. And the others, one study shows the congenital defects like air pollutants like particulate matter 2.5 that leads to the pulmonary stenosis and tetralogy of palate and orofacial defect. This study also supported the congenital defects. And other some studies that also leads to coarctation of aorta and tetralogy of palate due to nitric oxide and sulfur dioxide. And PM10 increases the risk of arterial septal defects. And we know other new thing that ambient air pollution that leads to low vitamin D levels in the newborn. And how to prevent to reduce the negative effects of air pollution by evacuate the safer area. Already I discussed about the air quality index. We have to take the safer area or safer side in the a place and install carbon monoxide detector, home inspected from the mold, and wear face covering when using cleaning products, and do not smoke inside or allow any else to do. And we know some soil pollution that affect the fetal like some heavy metals like lead, arsenic, mercury, and some polycarbon hydrocarbons. These are the exposure pathways of soil pollution by eating contaminated vegetables and soils and direct skin contact with skin that also leads to the exposure. The WHO top 10 chemicals of public health concern that air pollution, arsenic and asbestos, benzene, cadmium, fluoride, everything is leads to the chemical pollution that leads to the lungs. And environmental chemical exposure, we know the maternal factors, some effects in mitonutrient availability and vasoconstriction and hormonal activity that leads to implantation, growth and nutrient transfer of the placental factors that affect the epigenetics and organ toxicity and hormonal activity of the baby. And the heavy metal like lead, it is shown it's in the paint or soil or in the water, and that leads to cognitive impairment and creating attention disorders like hyperactive and deorganized behavior, and delayed growth and puberty can also result by the lead toxicity. And also adverse effect of lead exposure in pregnancy include miscarriage, low birth weight and neurological delay, anemia, encephalopathy and skeletal abnormalities. Developing nervous system also affects due to the lead toxicity. And some children intellectual and behavioral deficit also happen. And the mercury also we know by the consumption of fish with the high levels of mercury will show that also leads to neurological effects, and that leads to the learning disabilities and high rate of miscarriage and limb defects. And heavy metals like cadmium that also leads to the neurological dysfunction, and some heavy and trace metals like excessive copper level that leads to IUGR and preeclampsia, then some neurological diseases, and chromium that leads to developmental defects and malformation, and arsenic that leads to childbirth and abortion, and cadmium that leads to teratogenic effect. And this is some pesticide that persistent organic pollutants, pesticides and insecticide and fungicide that leads to lower psychomotor scores and decrease the IQ of the baby and memory of the children in future. And this is endocrine disruptor effect of the pesticide. That means that decrease or increase the normal hormone level in the body, and it affects in the fetus that leads to the changes in the outcome of the fetus that leads to the more dangerous things. And endocrine disruptor effect is mainly caused by dioxin exposure during the fetal development time, that other cause of carcinogen. And this is the action of pesticide, the direct damage to the cell and that impair the fertility and make effects on fertility that make abortion, stillbirth and premature babies. And DDT and DDE both are, we know that it causes endocrine disruption effect, and sometimes it causes cryptorchidism and accessory nipple formation in the male newborn. And DE also affect the correlated between gestational age and low birth weight. And this is some study shows that organophosphorus pesticide that related with the cognitive deficit and behavioral deficit. And this is a polychlorinated biphenyl that also affect the impaired brain development with the result attention to IQ deficit. The study is supporting for that. Mutagenic effects of soil pollutants like polycyclic aromatic hydrocarbons and some other chemicals that make the mutation in the fetus, and that also leads to the epigenetic effect of the baby. The gene expression also changes by the fungicide or pesticide. And in benzene that another exposure that leads to the fetal brain deficit and neurological tube deficit. The study supported the benzene that leads to the spina bifida of baby. And some avoiding environment toxin in pregnancy, avoiding pain supplies and checking the quality of the tap water, and we have to decrease the exposure to pesticide and avoiding any cleaning supply labeled by toxin. And microplastic already discussed. Microplastic means the plastics that particle less than 5 micrometer that also enter into the liver, kidney, guts in the humans. So that is contaminated plastic additives that leads to the oxidative stress and inflammation or severe immune response to the baby. So we can see in picture microplastic that in the fetus placenta, it's in that green particle in the placenta and fetus. So we can avoid the plastics. And water pollution, already these are the sources of water pollution, maybe pesticide or heavy metals or nitrates and phosphates. And that also the nitrate more than 5 million per deciliter that affect the neural tube defects, oral cleft, and congenital cardiac defects and limb deficiency. And water pollution, chemical toxin that also leads to pregnancy loss and cardiac defects. And some radioactive water pollution that is the teratogenicity of fetus, and radon, then radioactive substance that causes the stillbirth. And this water pollution, we can do the infective causes like E. coli, listeriosis, or shigellosis. All are caused the miscarriages, chorioamnionitis, or infection meningitis in the baby. And other viral diseases or parasitic disease like giardiasis, toxoplasmosis, malaria, all leads to the infection to the baby. Some radiation that also causes a mutation to the baby. And uranium and radioactive things also affect the genotoxic effect in the human cell. That rate of male newborns was much lower than in the normal population. And the noise pollution, the last thing, that also leads to elevate the cortical level of the mother, that that is affecting the fetus to reduce the size of the baby, that low birth weight baby. And these are the sound noise pollution sources like household and social events and transportation. The maximum decibel scale is like Craxus, and second is jet plane like that. And also in pregnancy, some experts think that the pregnant woman should not be routinely around noise louder than 115 deciliter. And one study showed that the regarding high risk of small gestational age make the noise pollution and some congenital malformation. The step to minimize the impact of noise pollution, earplugs and earmuffs can protect, and very low frequency sound should be avoided, and sudden loud noises we can avoid. Do not lean up against or put your body in contact with the source of noise or vibration. And take home messages are avoid plastics, avoid burning fossil fuel, electric and solar cars, and protect water bodies from heavy metals, and protect soil from the pesticide, use organic food, and reduce the noise and radiation. Thank you all.
Excellent presentation, Dr. Naushid. I think even the fetus is not spared by the pollution, effects of pollution, and even air pollution is causing cardiac defects. So the situation is very alarming. So any queries, comments regarding fetal effects?
If no queries,
Kasaragod study, any studies?
endosulfan.
Endosulfan.
Endosulfan is actually world famous. I mean, we have become world famous because of endosulfan.
Teratogenicity was there, like.
Yeah. And,
But
even Government of India has studied, and it's proven that the effects are because of endosulfan. And in the year 2011, Government of India banned use of endosulfan. I mean, we started, Kerala government actually banned, and then it extended to central government.
really, the thing, it's still the effects of endosulfan are there now also.
Yeah, my first
So
slide
it's
told already
like
that.
a nuclear war or something like that. Such is the toxicity, and it's an important topic.
Not
So,
even humans.
animals also affected.
Yes, yes.
Anything else?
Okay. Now, I would like to thank Dr. Naushid and Dr. Mrinal Pillai. I request Dr. Mrinal to hand over a token of gratitude to Dr. Naushid. Thank you, sir. It was an informative session indeed. Now I request Dr. Premraj, Organizing Treasurer and Treasurer IAP Vadagara, to the dais to hand over a token of appreciation to Dr. Mrinal Pillai. Thank you so much, everyone. Thanks once again to all the dignitaries and delegates for your valuable presence. I take this moment to also thank all the organizers and PARCO Hospital for all their efforts that made today happen. The meeting is adjourned. Safe journey back home, everyone.
Meeting is adjourned. Thanks, Meeting is adjourned. Thank you.